for coming. Let's start just with a word of prayer. Lord God in heaven, we invite you here today. I pray that you would use our words to encourage and to provide incentivation for these people who are in small clinics and trying to do big things for you. Lord, we know that your Holy Spirit is what does the work, and we just walk in the works that you've prepared in advance for us to do. And so we want to listen to you and hear from you today. In Jesus' name, amen. I'm Teresa Price. I'm a PA, and I've been a PA for about 24, 25 years. This is our executive director, Nanette Mudiam. She has her master's in public health, and she also was an RN. It still is. Kind of. Don't ask me to do anything clinical anymore. And we work at St. Michael's Medical Clinic in Anniston, Alabama. Anniston is halfway between Birmingham and Atlanta. It's a town of about 20,000 people. We are a clinic with, I think, 6 paid staff. We see about 1,400 individual patients per year. So we're a small clinic. So if you're from a big clinic and in this room, you will not be impressed with the numbers that we're going to throw out there today. I wanted to read some scripture before we start, and I think this has been thrown out here during the conference already, but this is Matthew 25, starting at 14. It's the parable of the talents. For the kingdom of heaven is like a man traveling to a far country who called his own servants and delivered his goods to them. And to one he gave 5 talents, to another 2, and to another 1, to each according to his own ability, and immediately he went on a journey. Then he who had received the 5 talents went and traded with them and made another 5 talents. And likewise, he who had received 2 gained 2 more also. But he who had received 1 went and dug in the ground and hid his Lord's money. After a long time, the Lord of those servants came and settled accounts with them. So he who had received 5 talents came and brought 5 other talents, saying, Lord, you delivered to me 5 talents. Look, I've gained 5 more talents besides them. His Lord said to him, well done, good and faithful servant. You were faithful over a few things. I will make you ruler over many things. Enter into the joy of your Lord. He also who had received 2 talents came and said, Lord, you delivered to me 2 talents. Look, I've gained 2 more talents besides them. His Lord said to him, well done, good and faithful servant. You have been faithful over a few things. I will make you ruler over many things. Enter into the joy of your Lord. And then he who had received the 1 talent came and said, Lord, I knew you to be a hard man, reaping where you have not sown and gathering where you have not scattered seeds. And I was afraid and went and hid your talent in the ground. Look, there you have what is yours. But his Lord answered and said to him, you wicked and lazy servant, you knew that I reap where I have not sown and gather where I have not scattered seed. So you ought to have deposited my money with the bankers, and at my coming I would have received back my own with interest. So take the talent from him and give it to him who has 10 talents. For to everyone who has, more will be given, and he will have abundance. But from him who does not have, even what he has will be taken away. And cast the unprofitable servant into the outer darkness. There will be weeping and gnashing of teeth. I wanted to read that just to remind us that we're not all going to be huge clinics, and maybe that's not ever in our future. Maybe you, like us, work in a small town, and you'll probably stay a small clinic, or maybe you're just in one small neighborhood of a big city, and that's what God is going to have for you, or at least that's what God has for you now. But with the 1 or the 2 talents or the half a talent that you have, I want to encourage you not to bury it in the sand, that you can invest it in the kingdom, use it for God's glory, however big or small it might be. And then at the end of our days, we can say, Lord, you gave me this, and I'm giving it back to you. And we can let the Holy Spirit work and do his work in us, big or small. So I'd like to introduce Nanette.
So we're going to talk about, can you hear me? We're going to talk about today how to leverage your resources to best manage your patients, okay? Because that's what we're in it for. We're in it for the patients, right? So a quick history. St. Michael's Medical Clinic was started by the Church of St. Michael's and All Angels, an Episcopal church, in 1988. So we've been around for 36 years. We operated for many years as a ministry type of clinic. They built this clinic across the street from their main beautiful campus, and they had one provider and they had one church volunteer. Now, in the beginning, that's actually not how it started. It started by a physician in the church who wanted a space for an internship program. He was doing medical residence, and they needed a place to do adult health in the community. So that's why it started, but it morphed into this kind of one provider and one volunteer. Now, this was a paid provider. They had money in the church that they set aside to do that, and that's the way it developed. And so our state association director in the state of Alabama says, if you've seen one clinic, you've seen one clinic. Like, we all run differently. Every free and charitable clinic runs based on the resources and the people and the passions that God sends you. So whatever we're going to say today is our experience, and some of it may be helpful and encouraging to you, and those things that are not, just let them go, because it may not be how it works out for you. But this was the model that I walked into, and honestly that we've kept. And I'll tell you why, that I do believe that the model is worth considering if you haven't already as we go by. So we had this free lease of this maybe about 3,000 square feet building. I started in 2014. I was doing a master's in community health nursing, and somebody on their board decided it'd be a great idea to have a student do that as the first ever executive director. And why somebody agreed to that, both my university and that board, I don't know. I had no experience in the nonprofit world before that. I was a registered nurse in a community health setting for about a decade before that, and so this was all new to me, so I've had quite a long learning curve for the last 10 years. Teresa started in 2015, having a background as a missionary, a PA in Haiti, and it was just, honestly, and I say this with all sincerity, I feel as if I am there to support her ministry to our patients. If you have great leadership, that's wonderful, but obviously you also need a great provider. You need someone who loves and cares about patients, and so I'm here to serve her ministry. So the first thing we did is we needed to leverage our space. So in this 3,000 square foot clinic, it was half a meeting room and half a small waiting room and 3 exam rooms, one of which had been converted to an office and one was kind of a dispensary. And when I first came, what I realized was, like, it didn't take any time for us to grow, because if you build it, they will come. If you make a space for patients in need, they know you love them and care about them, they will come. That's just how it is. Now, one thing I will say, when I got here, when I got to St. Michael's, the clinic had really fallen into a lot of apathy. They were seeing a max of 6 patients a day. That provider was being paid way too much to do way too little. And they made it a really high barrier. You needed a lot of things to qualify. And I said, we're not going to do any of that. We're going to take patients. We need qualifications. We need to prove to our funders that we're serving. Our mission is to serve low-income, uninsured residents in our county. But the next thing that we're going to do is we're going to make it easy for patients. And I'm going to take away all appointments. So our clinic is walk-in only, okay? We don't have any complaints about no-shows because we never have any. Because people will come. Now, sometimes they ask us, like, I need an appointment, and we're like, we don't give an appointment, but I can remind you, you need to come back in 6 weeks, or, and if you call me in 18 months' time and ask me to refill your meds, I'm going to say, I haven't seen you in 18 months, you have to come once a year or twice a year or whatever it is Teresa has prescribed. So I won't say that that's the best for quality outcomes, but I will say it's the best for our patients, because if they need to be seen, they can come in and be seen, okay? It also doesn't do a lot to prevent frequent flyers. We have some people who would love to come see Teresa every week. But the Lord has been really good in that. We just recognize that those people need us for that season of their life. So you might want to consider physical modifications, consider modifications to your rules of engagement with your clinic. You might want to figure out, how do we make this a welcoming space? So we literally took our meeting room space, which we decided Patients don't like to do a lot of education anyways. That's a kind of a barrier, and we'll talk about that a little bit more. But we took our meeting room, we cut it in half, we put some offices in the back, we put a supply closet, we put a workspace for volunteers, and we made a much larger waiting room. And so that worked for us. So you might just want to consider, I know a lot of us are in charitable buildings, or we're in buildings that are part of a church, or, you might have to make some modifications in that. Another thing you might want to consider is going paperless. Paper charts take up a lot of space. And I will tell you, we still do have paper charts, but the only thing that's in our paper chart is eligibility. It is for grants, and by the end of this year, I'll be getting rid of that too. I'm gonna make my front desk go digital because I need to save space. And it's not a good use of space, and it's also so much more efficient to use an EMR. So I know that some of them are cost prohibitive, but we use Practice Fusion. We get Practice Fusion through our membership through the National Association of Free and Charitable Clinics, and so you may want to check into that. We value our membership here at CCHF, but we also really value our membership with NAFC because it does get us some discounts and access to things like that. Okay, so consider that.
And I also, having had the background as being a missionary, I had no clue how to use EHR. I'd been paper charts for 12 years. We used to fan them out in the lawn after like a cyclone would come through, and so when she said EHR, I was really nervous, but there's a lot of them out there. Practice Fusion is one that are extremely easy to navigate. So if you have some providers that are nervous about it, just make them do it, and they'll do it. It'll be okay.
And I know a lot of other clinics. I know, Christy, y'all use Athena Health, right? And is it discounted through NAFC? It's free too. So there's another resource. So Christy's another Alabama clinic, not so far from us. So first, leverage your talent pool. Use who God sends you. We have to recognize that if this is a faith-based missional effort, then we got to use who God sends. I've only ever wanted to fire one volunteer, and I prayed her away. She finally did leave. And you have to do that. You have to recognize when somebody is not good for your team, when they might be toxic and have some things that they really need to process. But who are you, and what skills do you bring to your clinic, your staff, your volunteers? So this lady over here in the blue on the end is a 25-year bookkeeper for us. And she predates me. She was not so sure about me when I came, and she didn't much like me, to tell you the truth. But what I realized with her when I came is that she was very protective of the organization, and she had been put at the front desk. Remember I said it was high barrier? It's one of the reasons was because of her. She was a bookkeeper and very exact, and she didn't really have a personality that liked to interact with patients. And I said, Dottie, what do you like to do as a volunteer? And she said, I love the bookkeeping and I love medical records requests. And I said, well, then you just do that. That's all I want you to do. I want you away from the front desk, and we will find somebody else to do the front desk. And it brought her so much joy. She's so much. Don't you think she's so much more joyful because she does what she likes to do? So my key to you on volunteers would be to say to people, let them do what they love to do. That's what volunteers, that's the passion that will keep them coming to volunteer, okay? The next lady, Kathy, she came as a volunteer because she has a heart for ministry, but she's a retired pharmacist. And it didn't take long, and she's also a very, very detailed person, like very detailed. She tells me on a regular basis how I could be doing my job more efficiently. But she came as a volunteer, and we couldn't send her home through COVID. She wouldn't go home, even though she was in a more high risk. And we really found out we couldn't live without her. And she basically runs our dispensary, out of which we gave $3.8 million worth of medication out of last year. So she's managing a lot. So she does work for us. And the next kid is a tech who came to us as a pre-PA student. And One thing I will say to you, and if you're not doing it already, you got to find the pre-med and the pre-PA students in your neighborhood, because they will make the best techs for you, whether they work for you or they volunteer for you. They are worth it. He's the second, no, he's actually the third or fourth one that we've had. Anne is the next little short lady is a retired school teacher, and she speaks Spanish. She's bilingual. Half of our staff of 6 is bilingual. And so she manages the front desk with a lot of work, like a school class. She's a teacher, and a lot of our patients are kind of, some of them are kind of stuck in a certain, stage of development. It's very good that she manages the waiting room quite like a classroom, and she's fair and loving and kind, but she knows when to draw the line. And then that is Myra. This is leveraging relationship, because I'm a member of the Chamber of Commerce. I ended up sitting next to a girl who runs a phlebotomy school at one of the chamber meetings, and I said, I'm looking for a tech who's bilingual and who I maybe can develop skills in, but I need somebody and they're so rare, especially in Anniston. And she said, I have the student for you. And she sent her to me. So we have to leverage the relationships that we have. You got to get out in your community. If you're the director and you spend a lot of time in your office, you're in the wrong space. You got to get out. You have to go to the meetings. And I'm actually not an extrovert, and I'm not the most social person. I would much rather stand here and talk to you than probably stand and talk to you one-on-one, just to be honest. Because I'm just not by nature social, but I have to be, because that's what this job requires of me. And because I feel passionate about this, it's not hard for me. So we cultivate our relationships, and you got to use, so we have a local university. I did my master's there. Out of those relationships, we have BSN and NP students who come and work with us. We leverage the students because they're good volunteers, right? I also leverage all the relationships I had in my community health nursing. And my kids will make fun of me that if I see a specialist across a parking lot in Target, I'll be headed towards them, okay? We have to do what we have to do to network and to believe that God is ordering our steps in order to allow us to connect the right people. Okay. All right. I'll give it over to Teresa.
I got to use this. I'm sorry.
Yeah.
Leveraging your skill set. Just talking about talking to the clinicians, or those of you who are looking to staff clinicians. One thing Nanette did was hire me, which is nice because I don't have to have other jobs. I can just do this. My patients can say, "Where else do you work?" And I say, "I work for you. This is where I work," and it's a blessing to be able to do that. But one of the reasons she can is because I'm a mid-level. I'm a PA. We're cheaper than hiring docs. So think about your mid-levels. Mid-levels is a good use of your funding, and then just to talk to any of the clinicians in the room. If you learned it once, go ahead and do it. In clinic, there's, I learned this in Haiti, right? So I'm a missionary for 12 years over there. I did a lot of things over there that I don't do in the States, like pulling teeth and birthing babies. I don't do that anymore, but there are a lot of things that are in my purview here, legal in the States for me to do, that I do that even you're not going to find your normal family practice doing. And it's because, I learned it in school, I can do it, and if I do it, then we don't have to refer it. We don't have to send them to a specialist. They don't have to go to 2-3 visits. So if you learned how to suture in school, which we all did as mid-levels and docs, do it in your clinic. The surgical office-based procedures, opening abscesses, I'll give a patient an IV if their sugar's, high. Just those little office-based procedures really can save them an ER trip, save them a specialist visit. Casting, and I'll talk more about that, reading x-rays, PAPs. There's some people who just want to give that to the health department or give it here or there. If you can do it, it saves them time, it saves them a trip. And then when it gets to treating complex disease, the words on there, mande pa péché, they're Creole. It's a Creole proverb for it. It means to ask is not a sin. And like Nanette said, asking for help from specialists. You know, you see them, maybe I went to the ortho and then for something for my problem and then said, hey, I work at a clinic and could you help us? You know, to ask is not a sin. Ask the specialists in your area to help you by phone consult, and that will save you. A lot of them are seeing patients that can't pay them because the hospital is telling them after the ER, you know, you got to see this patient as a follow-up or whatever. They don't really want to. They're not getting reimbursed for it. They would much rather tell you what to do with that patient and have you deal with that patient. That's what I've found. So I have a bunch of them on speed dial. One instance would be an ortho. I have him on speed dial. I'll text him. If he's not in surgery, he texts me back. I'll say, hey, I got a patient from the ER. They're in a splint. They broke a bone. Read the x-ray for me because we share, you know, he can look at those x-rays from the hospital and tell me what to do. Because, of course, the ER is going to tell him, go to see the ortho in 2 days. That's just their standard, go see the ortho in 2 days. They don't, half the time they don't need to. Half the time they need a short arm cast or a long arm cast, and then they come back to see you in 6 weeks and you cut it off yourself. As long as you've got an ortho telling you, yeah, that's what I would do with that. So more than half of the people that come to me with a fracture, we're able to deal with in the clinic. And then the others, the other unfortunate souls who the ortho says, hey, that's surgical, then we have to prepare them to pay the $250 to go see the surgeon and deal with all the bills. But it does save some. We've got rheumatologists that I can call. You know, as primary care, I'm always encouraging people, you know, Plaquenil, methotrexate, it's, as long as you have access to labs and that person is going to come back frequently, don't be afraid of those. And, you know, as long as they don't have a substance abuse addiction, things like that. We also have access to eye care, so we can start Plaquenil and get them an eye exam every year. And then if they need to move on to a biologic, I've got a rheumatologist that'll tell me on the phone, okay, do this one, do that one. Infectious disease, we have a lady with Voigt, Koyanagi Harada syndrome. I can't even say it. But we diagnosed it because we sent her to the eye doctor, and he said that's what she had. And I looked it up, and I said, oh, yeah, that is what she has. She needs high-dose steroids. Uh-oh, she's a diabetic. Uh-oh, her PPD is positive. So we actually dealt with all of that just by leveraging my contacts with infectious disease and with endocrinology. And so you can do more than maybe you think you can, as long as you're talking to the right people and getting advice and not being afraid. Like, I'm not prideful, but I was like, I have no idea what I'm doing. Can you help me? And I guess it helps that I'm a mid-level. You know, the doctors are like, oh, those mid-levels, yeah, they're always needing our help, you know. But it's, you know, it's nothing for me just to say, can you help me? And they're always willing to help, especially if it's one less uninsured person that they would have to see. So, and then one final encouragement is don't be afraid of psych. As you've seen in other breakout sessions, everyone who's suffering in poverty has had trauma, right? Most of our patients have psychological issues. Even those who aren't poor, you know, most of our patients have psychological issues. And so the clinician before me, she said she wouldn't see any schizophrenics, she wouldn't see any bipolar. She had a long list of psych patients she just wouldn't see. And we've developed relationships with mental health services. A lot of patients are discharged from jail in my city and not given their meds. And so 2 weeks later, they come back and they're in a manic state. They're about to commit another crime. They're wanting their meds. They can't find someone to prescribe them. If they go to mental health services, they have to go for 3 sessions of counseling before they get their medications. So, you know, we give them their health meds. We give them their mental health meds, the meds they were already on, the meds they've been prescribed, and then we hook them in to psych so that they can get the counseling they need. So don't be afraid of psych. We see a lot of patients who have schizophrenia and bipolar, and we've had to call the cops maybe once. So don't be afraid. And keep learning. You know, if you don't know how to do a joint injection, learn how. You know, just all the different things that a lot of these things we do at my clinic, joint injections, removal of toenails, incision and drainage of abscesses. We don't do wet mounts, but you can do those. That's an idea. You know, just have have a microscope on hand and do your own wet mounts. We used to do those in Haiti. And then the biggest thing that I would really push for any of you who don't have this is point of care ultrasound. It will save your patients a ton of ER trips and unnecessary specialist appointments. So I used an ultrasound machine in Haiti. I got really used to it. And once you're a clinician and you're used to it, it's almost like your stethoscope. You feel kind of naked without it. And so when I moved to the States and started working with Nanette, I said, Nanette, we need an ultrasound. And so she sent me to Gulf Coast Ultrasound Institute. I got specialized training on it. She wrote a grant for all of this, right? You just grant funders like that, the one and done. So we'll give you a grant so that you can get your training and get your machine, and then we're done with you. And so went and got my training. The doctor who is my supervisor also went and got trained. We have our machine. It's still working great. Mm-hmm. And for instance, some of the things that I'm able to do to, you can rule out an acute cholecystitis, see if they have gallstones. Now they're not going to have to go to the ER to be told they have gallstones. You just set them up with surgery. Thyroid nodules, you can just measure those, put them in the TRADS calculator, see if they need a fine needle aspiration or not, follow those up every 6 months. There's a lot of things you can do in office with your ultrasound point of care, and it was not a lot of time, not a lot of money. Here's some resources. Gulf Coast Ultrasound Institute is in Tampa. I highly recommend them. They have courses anywhere from 2 days to a week. You can do, you can learn abdominal, you can learn emergency, you can learn OB, pelvic, all the things. And the prices range from about $500 to $4,000. And same with the machine. I don't know how much the one we have cost, but yeah, a wide variety of different kinds of quality machines you can get. Just depends on your budget. But if you look ahead of time at what you want, mande pa peche, right? To ask is not a sin. So you say, hey, I want this really fancy one, and I want to go to class for a whole week. And then you just write the grant for the money and see what God can do. Office-based PFTs are a good way to save pulmonology referrals. If you can, this person has COPD. They've smoked for 20 years. They got the hacking cough. They've just never been diagnosed with it. If you have an office-based PFT, it's easy. And there are some, I put a link here, that don't require a lot of calibration, because that's always the problem, is trying to find a staff that can keep it calibrated for you. We use a lot of point-of-care labs. A white count. We've got the HemoQ, so that'll do a hemoglobin and a white count. And then we have the DCA Vantage analyzer that does our A1Cs. And then, of course, you have all the urine-based tests. And so we've got...
COVID, flu.
Yeah, COVID, flu, strep, mono. Anything that you can do point of care in your clinic, you're going to be saving time and money in the long run. And then there's also an app called Visual DX, and I'm not sure how much it costs, because we got it free through one of our connections with NAFC, but it helps you diagnose skin diseases. And like I said, don't be afraid to biopsy, because you send them to the dermatologist. That's all they're going to do anyway. Throw some steroids at it. If that doesn't work, biopsy it, right? So, and we do have a relationship with the lab in our area, so that she writes grants so that we can pay for the labs for our patients. So that is one thing. If you're going to do comprehensive primary care, you have to have a way to do labs. There's no way you could do really any of this comprehensive care without a way to do cost-effective labs for your patients. Yeah.
We have a contract with our local CPL lab, and they drastically reduce the cost of everything.
Same with us. Absolutely. You just ask your local lab, and they'll give you their base rate, which is a lot less than they're charging the insurance. Legal ramifications for mid-levels, in case you're worried about getting a mid-level to work at your site. We can work without our collaborator on site, depending state by state, and that collaborator has to be on site for a certain amount of hours, and that all depends on your state and on the amount of experience that your mid-level has. So you just have to keep up with the laws in your current state, make sure you're following the laws. The mid-level can, really as a PA, I'm not sure about NPs, but as a PA, I am legally able to do anything,
That your docs do.
anything that my doc does, and diagnose and treat anything that they do. And if it's beyond that, I just have to tell the state what I'm doing and get approval for it ahead of time. So,
Yeah. The one thing too that I would say as a follow-up to that, especially for those of you who may not be clinical, that you might be in administration, is to support your clinical team to practice to the edge of their scope of practice. Because like we said, this is how we provide comprehensive primary care. It's by doing everything that we can do for a patient while they're on site. Because when they leave us, we don't know whether they're going to have the transportation, the funds, and the access to get the care they need. The next thing is to leverage donations. We believe in the philosophy of saying yes. We like to say yes to volunteers. We like to say yes to donations. And people bring you stuff that, quite honestly, you don't always want. But honestly, very often there's something in there that's really valuable for one of your patients. So you end up being, a repository for a lot of junk sometimes. So I do say yes to everything, and then I have a team that goes through that. My basement is very often full of those kinds of things at home. But because of collaborative relationships this year, another local relief agency that does ministry to the homeless, and they do prescription assistance program and a few other things, they said, hey, we'll start a durable medical equipment closet, and we'll keep it organized, and if you'll just bring it to us, we'll clean it, and you just send them to us. The only thing we ask is we want it to be used. We don't want this stuff to just sit there. So we've had to do some marketing around it so that the community knows that it's there and it's available to anyone. But we want to keep this stuff. We want to be good stewards of the stuff that's in the earth. Like, no more needs to fill a landfill, right? No more needs to be purchased when it's already available, when you have a perfectly good wheelchair. Let's be good managers of resources. And so I also found a couple of agencies that do international work. And so a lot of, like right after COVID, did y'all get tons of donations of needles from vaccine that didn't get given? And so I gave it to I have a company who does a lot of shipping that takes my couple of boxes every couple of months and ships them to organizations. There's one based outside of Atlanta that takes it. You can email me if you want to know who they are. And there's another one that takes ostomy supplies. And so those kind of things that maybe they're for more of an acutely ill patient that you may not be seeing in an ambulatory setting, you can send them out. Let's try to meet the world's needs with this leftover that we have, right? That's about being good stewards of those talents that have been given. Obviously,
and I would say too, just to pray about it sometimes. If it's an oddball donation, maybe pray and see if it's something you shouldn't keep, because there's more than once that we've kept a random odd thing that within a week we've had a patient that came in and needed it, and it just happened to be on our shelf. So.
And there's a lot of people who do a lot of things, like people will give us hearing aids, like that's a very valuable item. And there's an agency in the U.S., I have to Google them every time and I have to mail it to them. Sometimes if I think the person who's calling, I might say, there's an organization that you can ship that to directly. But if I think that they can't or they don't have the resources to do that, I'll just say, well, bring it to me and I'll make sure that to get it in the hands of somebody who needs it. Listen, I'm one of those people that believes if we don't get sticky hands, God will give us everything we need. And so we just let it flow through us. If we can use it, we will. If we can't, then we'll believe that somebody else will come in our path who needs it. We don't let patients volunteer, and we do see a lot of patients who are in rehab facilities for drug drug addiction, but we do find that there are other ways that they can give back. We've recently moved, and so there was a lot of, grunt labor that we needed, and they were so eager to do it. People ask us all the time, can we do something for you? And they're so happy when you call and say, hey, I need you to move these benches so that I'll have a smoking area, outside of my clinic. Confessions of a real free clinic. Oh, yes. The other thing is, if you're not using AmeriCare's Direct Relief and Medication Assistance Program, a Medication Assistance Program is here, MAP International. Oh, yes, I'm sorry. It is. It's Medication for All People. I'm sorry, they changed the name, and that one is stuck in the original one is stuck in my mind. But they're in Georgia, and we found them through St. Clair. So have relationships with people. I would say, a lot of what's happened in us is just purely out of relationship, out of our state association, out of talking to other nonprofits, in networking. The resources will come to you.
Have you used patient assistance program directly with the pharmaceuticals?
Yes, and she's here today. And Beth is.
Oh, no, she's talking about PAPs.
Oh, yes. Okay, so yes. You absolutely have to use PAP programs, and I'm going to tell you why it's not listed on there for me. It's because another agency that is 5 blocks from me has a full-time employed person who does PAP programs. And so we refer them to them, because why am I going to pay someone to do something someone else already does? But that changed. We do one PAP program for one disease. It's Hep C, because HIV, the HIV center used to handle Hep C in our town. They stopped doing it. And we said, nobody, who's going to do it? Well, nobody was there to do it but us. So Teresa got trained. Another thing, like, okay, is this in our scope of practice? Can we do this? We had a collaboration with UAB and their infectious disease department. They actually had a little grant funding they gave us in the beginning. They trained her. They consulted on all the patients. And then she got to be good at it. She's 3 years in of doing Hep C. So we do the PAP program for Hep C, but that's the only one we do. We do really try to allow patients to give back. About half of our patients are undocumented Spanish-speaking patients, immigrants, and they have an annual fundraiser that they love to do for us. Teresa spends a lot of time in their community because she is bilingual. We allow patients to give testimonies and use them in our annual signature events. And then this is something we've just started, is having patient representatives for our board. And so just allowing, the best kind of relationships, now it's not possible in the world, but the best kind are mutually beneficial, right? It's mutually beneficial for students to come into our clinic. They're quality volunteers for us, and hopefully they're witnessing medicine at a young age and hopefully having a heart for Jesus and service in the future of their medical careers. But we recognize that if it can be mutually beneficial, then it's a blessing to everybody. And so it can also be that way, like Brianna Latham was saying this morning, that our patients are a blessing to us, that they have wisdom to share with us, that they have encouragement to give to us, and that it's not just a top-down ministry, that it's mutual, and that we can share life with our patients. So this is something we're in a small town. So we serve our county, which is about 140,000, so this may not be possible in a bigger area. But in our town, we don't duplicate services like the PAP program. Somebody else is doing it. I don't need to do it if somebody else is doing it. We are really careful with our resources. So. About when I first came to this job, our hospital said they made a public announcement that they wanted to start their own indigent clinic. Well, my board reached out to me and said, don't they already know there's already a clinic for the indigent, that we don't need, they need to just work with us. And I had previously worked for that hospital and I had relationships with them, but I just said, no, if they start a clinic, then the only thing that I'm going to ask them to do is be open on days that we're not. To do things maybe we don't. Maybe you could coordinate. Because my ultimate goal is that patients have access to health care and hopefully find the love of Jesus along the way, right? So I'm not interested in who gets the credit or how it happens. I just want patients. I believe in universal health care. I think health care is a human right. So that was never my interest. So along comes COVID, and we get a seat, as many of us did, at the table because they didn't have anybody to deal with these people that we deal with, right? The homeless, those who are struggling, the immigrant. How do we deal with COVID for them? So we had a seat at a table. And again, they started this conversation about their commitment to starting a clinic for the poor in our community. And so I said, you know what? I will tell you everything I know. Everything I've learned is not long. I haven't been in this business a long time, but I'll share with you everything I know. So I did. I went to several meetings and told them everything I know. I went to maybe the third or fourth meeting, and I thought, you know what? I've told them everything I know. I don't have anything else smart to say. You know, I'm out of ideas for them. And there's probably better uses of my time to keep going to this meeting. And so I was prepared with my little spiel, like, you know, I've told you all everything I know. And they said, no, we've decided we want you to run the clinic. And not only that, but our hospital and the city are going to invest money into renovating a building that will be bigger, and will have this and this and this, and what do you think it should have, and we'd like you to run it. And at first I thought, oh, that's a great idea. I can run theirs a couple of days a week, and I can run St. Michael's a couple of days a week. And then a few months in, I realized, like, no, that's not a good idea for me, because that's not personally it's going to be personally hard on me, but also confusing for our patients, like, where do we go today? You know, where's a clinic that's open that will meet my needs today? And I will have to duplicate resources, and I'll have to get another sonogram over there, and I'll have to do all these things, and I don't want to do double the work. And plus, I'm busting out of the clinic I'm in. So you know what? I think I'll take your clinic, and I think I'll move over there altogether. And you know what? They went for it. So I went from 2 days, then eventually went to 3 days, and now we're at 4 days, and by the summer we'll be at 5 days. And in a totally rent-free, maintenance-free, brand new building in the heart of my city. So, you know, your clinic, let me make sure that I covered, yeah. So this is another thing I want you to know. Cities are looking for solutions to the problems that we face. And one of the things that I do in raising money is I never present need. I present a solution. Because we're God's people, and we have the answers to the problems that people are facing. And I can't solve all the problems in my city. I can't solve education. I can't solve homelessness. I can't solve poverty. But I can give people compassionate health care. We can. So, and that's maybe all I can do. But we can give people the. So when we come to the seat at the table and say, I have solutions to offer, then people are willing to invest in that. They are willing, they are looking for people who can produce results. So yeah, you gotta know your data. You gotta know your story and know how to tell it. And when you do that, you can be a small clinic that has a really big impact. That you know, the amount that we did, that was at, my 3.8 million is out of my dispensary. We connected with our hospital to give away the hospital gave away $4 million worth of charitable care to our patients alone last year. So you can do a lot when you just trust the resources that you've been given, that are in your hand, that God sends to you. And so it is possible for a small clinic to have a really big impact. And we don't know everything about it. We don't. This is just our story. When we do the work that God's called us to, He can really help us to have a big impact. So I really thank you for your time. If there are no more questions, then we'll say have a great evening. Thank you. Thank you.